Welcome. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us for this CMEO snack titled PrEP Inequities. This program has been supported by an educational grant from Gilead Sciences, Inc. I'm Dr. Oni Blackstock, founder and executive director of Health Justice, a racial and health equity consulting firm. I'm also a primary care and HIV physician. I'm excited to be joined today by my esteemed colleague who will now introduce himself.
Hello, Dr. Blackstock. It's an honor to be here with you as well. I'm Vincent Ramos. I'm the Dean of the Duke University School of Nursing. I'm a nurse practitioner, both certified in primary care and also in psychiatric mental health nursing. I specialize in caring for individuals living with HIV. And I would say that I particularly focus on the Latino community, but obviously care for a wide variety of patients, but have been working with Latinos for probably about 20 years.
Wonderful. Thank you so much, Dr. Guillermo Ramos. So I'm just going to say, to frame the discussion today, I want to briefly review our learning objectives. First, we want to address healthcare provider bias and inequities in clinical approaches to sexual health and PrEP discussions with Black and Hispanic Latino patients. And then second, we want to address structural barriers to individualized PrEP care that would optimize patient outcomes. First is some updates around PrEP guidelines, who is it indicated for, who's eligible, because I know we've had some recent updates over the last year or so.
So that sounds great. So I think generally we think about individuals who have indications for PrEP. We're talking about anyone who's sexually active, who is an adult or an adolescent, who reports anal or vaginal sex in the past 6 months and has any of the following. They may be having sex with an HIV positive partner that is not virally suppressed or is not undetectable or has unknown status. They may have, in the past 6 months, a recent onset of a bacterial sexually transmitted infection, or they may have a history of inconsistent condom use or no condom use. These would be sort of key PrEP indications. In addition, for people who inject drugs, they may have an HIV positive injection partner, or they may be sharing injection equipment. In terms of some of the clinical eligibility, they've got to have a documented negative HIV test within 1 week before initiating PrEP, and every 2 to 3 months thereafter, an HIV negative test result. They also have to have no signs or symptoms of acute HIV infection, and they have to have no contraindications in terms of other medications or any sort of issues in terms of their health status that would contraindicate initiating PrEP.
Great, thank you. So it seems like there are a number of different groups of people who could potentially really benefit from PrEP, and mainly folks who may be sexually active, folks who may be injecting sort of in general. And then also it seems like, just in terms of the clinical indications, generally, if someone doesn't have acute HIV infection, as you said, underlying kidney disease, PrEP is a safe option. Just to move on a little bit, it's so wonderful now that we have a number of options for PrEP. And obviously, just for those watching, just remembering that, PrEP is a really highly effective way to prevent HIV infection in people who are HIV negative. And I always think about my patients, I feel like the more options we have in terms of taking a medication, whether it's pill, injectable, other delivery options, that sort of allows people to find what is the best fit for them. To most of our audience, you may be aware that there is Truvada, or the first approved oral form of PrEP that is indicated for preventing HIV transmission via sex or injection drug use. Generally well tolerated. We know, I'm sure, Vincent, from your experience, some patients can have over the first few weeks kind of a startup syndrome with some nausea, maybe some belly pain, maybe headache that typically resolves after a few weeks. And some folks can experience weight loss there's some, if people have underlying conditions, can be at risk for toxicity to the kidneys and to the bones, but generally overall is quite safe. And then, more recently, we've seen the approval of Descovy, another oral option for folks who are engaging in sex, but it excludes folks who are engaging in receptive vaginal intercourse. So just a note around that it's not approved for individuals who are engaging in that specific sexual behavior. Also relatively, I think, well tolerated. Maybe you could share what your experience has been prescribing to patients. And, I always say it has a different side effect profile from Truvada versus like a better profile. We know that like Truvada, the bone and kidney stuff can be of concern. Whereas I think we see less of that with Descovy, but we may see more weight gain and, cholesterol and lipids being affected. Just curious what your experience has been.
I completely agree with that. It's beautifully stated, Oni. I think because I work with so many young people, I think one of the challenges is that they may be hearing some of the misinformation about Truvada that has been, in my view, sort of exaggerated. And so they may come in sort of requesting Descovy or saying that they don't want to take Truvada. And so I think it has been a useful tool in terms of providing options. I do want to point out, and I'm sort of curious what you think about this, but I also have relied on 2-1-1 with Truvada, helping people to have an intermittent dosing strategy, especially if they have seasons of risk, whether it's very frequent exposures and they don't want to take PrEP daily. It's not my first sort of go-to option, but it is something that I have used.
Yeah, no, I agree, Vincent. It's something that when I was working at the New York City Health Department, we really promoted citywide. Again, I think when people have different options to figure out like what works best for them, given their daily routine, given what's going on in their lives, including their sex lives, it's great to be able to offer that as like an additional option. And then obviously now we also have injectable PrEP. So a different way that folks can take PrEP medication. This obviously is a little bit different in terms of like requiring folks to come into the healthcare setting to get the medication. And so I'm just curious, have you seen or had patients who've maybe preferred injectable versus oral, and what were some of the reasons that they gave?
I mean, I think honestly, this is a game changer, and I have a lot of excitement and enthusiasm about long-acting PrEP and also long-acting treatment. But I know for today we're talking about PrEP. Yes. But in my view, this provides an opportunity for folks to move away from the daily dosing of taking a pill, and it reduces some of the burden of having to remember, of being concerned, what if I forget, what do I do? And it sort of really speaks to being more prepared and thinking about one's sexual health in a way that they can sort of plan, well in advance. I think, Oni, if I'm being really honest, and I'm curious about your experiences, in the clinics where I work, and I'm currently living in the South and in North Carolina in particular, injectable PrEP has not been something that I've seen widely in my clinic. And so I work in a Department of Health where I'm working with people who are primarily underinsured, uninsured, undocumented, people who are experiencing many psychosocial stressors. And so we as a clinic have not been able to incorporate injectable PrEP in the way that we probably would if we had more resources and if this was something that was more accessible to the masses. And so I'm curious what you're seeing in New York, where you are, and it's just a great highlight that matches the focus of what we're talking about today.
Yes, and I totally hear you. And I was hoping that you had a more positive experience than I had in terms of injectable PrEP, but again, also working out of a city hospital, so publicly funded. Again, many of our patients uninsured, underinsured, and we're just starting to create protocols around providing this as an option for patients, but having to get the approval from the insurance company to cover this. There's just a lot. There's some sort of organizational barriers that sort of need to be overcome, I think, to make this make access easier for our patients. But hopefully with time and sort of learning best practices and the experiences of different clinical settings, we can figure out what works the best and really make sure that our patients know it's an option. And then I think one point, just wanted to make sure that, I had a few patients who were cisgender women who were taking PrEP, and just to say that, I think some of the challenges that they experienced was, really having to take it every day in order for it to be most effective, where we know among folks engaging more in receptive anal intercourse or anal intercourse in general, that there's more sort of forgiveness in terms of adherence. So that's also an issue. And I think injectable PrEP can definitely also help with that, with folks who are struggling, as you mentioned, with having to take a pill daily.
Makes sense. That's yes.
Yes. As you mentioned at the beginning, you take care of a cross-section of patients, and in particular, the focus of a lot of your work, as I know, on the Latino community and the impact of HIV. And so I know you are very well aware with the inequities that exist. I think, Truvada, we know, was approved back in 2012. So we have almost more than a decade now of experience. But what we've seen is kind of these entrenched inequities in terms of who is taking PrEP. So although we know Latino and Black people account for a majority of new HIV infections, they account for Black Americans, about 8% of those who could benefit from PrEP are taking it. And then for Latino Americans, about 14%. What are you seeing as some of the challenges? And I know we'll talk about this a little later, thinking that we should have gotten better over time. This continues to be an intractable problem. Where do we need to focus?
Sure. I mean, what a great question, Oni. And I think there's sort of two things that I want to highlight. We could spend a lot of time on this,
yes,
but there are two things I want to share. The first is that I think you nailed it on the head, that, we have effective tools. PrEP is certainly an amazing HIV prevention pill or injection that really works. The challenge is, how do we get that innovation, that very effective preventative measure to the right communities? And as you really think about sort of the racial and ethnic inequities in our country around PrEP, it's pretty distressing, because these are system failures. These do not represent, African American, Black, or Latino individuals or other persons of color who are not, saying, hey, if they had an opportunity and they were offered PrEP, if it was accessible, if they had adequate coverage, if they could access a provider, if they were given information in a way that was health literate for their needs, that they, wouldn't take it. They will take it.
Yeah.
The problem is that our systems are not aligned with, the needs of the community. What's so distressing about this, which is my second point, is that because we've been so successful in reaching certain communities, and I'm going to focus primarily on the white MSM community, which that's terrific. I think any person who is at risk should be able to access PrEP. But given that we're doing such a great job there, it actually is sort of an interesting contradiction, that it further exacerbates the inequities. And so we talk a lot about, like, now the face of HIV being in certain communities, and we often will talk about those communities as being at risk. But what about the sort of inequity in our preventative measures that are fueling the inequity and the difference that is unfair and unjust? And we very rarely talk about that.
Yes, no, I totally agree. And I've often talked about, like, the browning of the epidemic. And I remember seeing a modeling study looking at time to the end of HIV epidemic for different racial ethnic groups in different cities. And there were maybe 4 cities that were focused on large metropolitan areas. And for some of them, in terms of epidemic levels of HIV, are no longer at non-epidemic levels for HIV for white Americans in those cities, but persisting at epidemic levels for Black and Latino people. So still so much work to do. And I know that you have some familiarity with, some different sort of strategies that are being used to reduce inequities. And I wonder also specifically about elucidating and getting a sense of, what is going on in terms of transmission. And so can you just talk with us a little bit about what we're sort of seeing in terms of HIV transmission and how that might inform HIV prevention strategies?
Sure. Great question. So I think, one of the things, Oni, that has been really striking is that the CDC has been doing some amazing work on detection of groups or clusters of individuals where HIV is transmitting more rapidly than what we would normally expect. And these clusters represent, in my view, and in the view of folks that are working on cluster response, system failures. It's a place where either our prevention or our treatment, which treatment I would argue, and I think many would, is also prevention, that it's not working, that somehow there's misalignment between our HIV prevention and treatment services and individuals who are most at risk. And so across the United States, what we see is that there are these cluster outbreaks, and these are places where there's a group of 5 or more new infections that are happening quite rapidly. And so there was a recent report that was done, that was published in the MMWR, that really identified 136 clusters where transmission was occurring across more than 1,200 individuals who were detected to be living with HIV. And this was in 19 different states. And then 19 states are across the 4 regions of our country. But I want to point out that there was a disproportionate burden in the South, which had about 10, if I'm not mistaken, of the 19 states. What was interesting is that across the clusters, when you start to sort of look in and see who is a member of the cluster, you see a couple of patterns that I think are pretty sort of symbolic of the inequity theme that we're talking about today. The first is that primarily MSM, so close to 70% of the individuals that are in the clusters identify as MSM. I think what's also true is that there's about half of the clusters are in the South, and the South has been an area where HIV, unfortunately, continues to thrive. And incidence in the South, new infections, continues to be more robust than where we should be given our ending the HIV epidemic goals. But it's not just the South, it's the Northeast, it's the Midwest, it's the West. There were clusters detected across the country. There's just about half in the South. When we think about race and ethnicity, we see disproportionate burden among African American, Black, and Latino. And so that those 2 groups represent more than, close to 50 or to 6, actually I would say 60% of the individuals in the clusters. And then a third are white. MSM. I think what's really striking and something of great concern that hasn't gotten a lot of attention is that about 2/3 of the individuals in the clusters are 30 years of age or under. And so again, young across the United States, but particular emphasis on the South, Latino, Black, but obviously not only Latino and Black, and young MSM. Overly represented in the clusters.
Well, yes, I mean, that's just, this sort of movement of the epicenter of HIV to the South. And we know, transportation, probably is a huger challenge. And you're located in North Carolina, so I'm sure you are sort of seeing a lot of this firsthand, and issues around, many of the states have not expanded Medicaid, so less insurance coverage. So lots of barriers that folks are facing. And I'm wondering, when you mentioned about the young MSM, like how about 2/3 of the men in those clusters were under the age of 30, and that is so absolutely striking and so devastating. And I'm wondering if you can, give us a sense of what may be a driver of that, that this phase of the epidemic is really impacting young men.
I mean, what a great question. I think only, my entire career has been focused on young people. And first and foremost, I would say that young people are largely invisible. And, we typically think of young people as being healthy. We tend to underestimate that they may be sexually active or using substances. We have tended to sometimes adopt services that are not very youth friendly. They may be really geared towards adults, and so they don't meet the needs of young people. We often have state policies that restrict young people being able to access sexual and reproductive health services to maintain their sexual health. We may have views that are sort of counter what's really happening in terms of our national appetite for really accepting that the vast majority of young people at some point during high school become sexually active. Again, I think developmentally, young people are experiencing their sexual debut, and they may not have had enough sexual education around how they can protect themselves. And to be honest, both the approval for the use of Truvada, which was our original PrEP, oral medication, and also when we think about providers making the offer to individuals, the approval was later for young people. It was much later in terms of ensuring that it was safe and efficacious for young people. And we just haven't done a good job as a country at having our testing, PrEP, and other sexual and reproductive health services reach young people. And I would say most disturbing is that there has been, in my view, sort of a direct attack on sexual and reproductive health across a number of areas, whether it be abortion and sort of the Dobbs case, or it be really around some of the states that are pushing back on federal funding for HIV prevention, or recent court rulings in certain parts of our country that are suggesting that employers don't have to cover based on religious objections, or just if I think about the complete invisibility of the fact that for more than 8 consecutive years, STIs have been increasing in our country, half of them, occurring in a given year among young people. And there's been almost no recognition that this is a problem and that we need to address it. There's a lot to say, Oni.
Yes.
There's a lot.
No, thank you for all of those really important nuggets. And we can see sort of how sort of vast, there's so many barriers and issues that need to be addressed. But I think, as providers, I think you made this point that PrEP, it's one of the few HIV prevention strategies that requires a provider to be on board and to share information about PrEP with anyone who could potentially benefit from it. And so it's really, incumbent, in terms of our audience that's watching, really if you have, all patients actually should know about PrEP. I always say everyone should know about it. It may not be, a good fit for everyone, but at least they're aware of it. They can share that information with other folks. And then we also know there's a lot of, there are providers who may not be culturally competent or linguistically competent. We know that also can be a lot of enacted stigma or discrimination. And we mentioned, mentioned a number of sort of laws being passed, but even just anti-trans, anti-gay sentiment can make it very challenging for folks to even come into the healthcare setting. So I'm just wondering if you could just, share with us a little bit more, if patients have shared with you their experiences of seeking care and having to deal with, homophobia, or just providers who are not trained, and what providers can really do to create a more affirming and accepting clinical environment for their patients.
Sure, it's a great question. I think as a provider, what I would encourage, and certainly what I teach folks who are seeking to care for individuals living or at risk with HIV, is the importance of really being open and non-judgmental.
Yes.
Really thinking through how they're assessing, getting a sort of a good sexual history, asking about partners and behaviors, not assuming, being sure that, in my practice, and, I've had providers actually say that I'm incorrect about this, but only I don't agree with that. I typically will do 3-site testing for STIs routinely, irrespective of what people are reporting, just because I feel that it is so important to just normalize and to really focus on sexual health, and not about risk or about doing something that is in any way stigmatized, but really that it's important for all of us to achieve our optimal health, and part of that is our sexual health. So that's how I approach conversations: very open, very non-judgmental, very much normalizing and trying to get the information that I need, and really trying to look beyond what someone might be presenting, because often in an interaction that is fairly focused, you might feel embarrassed. You might not want to share exactly what's going on. And so it's a missed opportunity to really just treat everybody in some ways the same, and saying, hey, we all need to get checked out, and this is really part of our sexual health.
That's so important. I'm so glad you raised that, creating a non-judgmental, sex positive environment for folks, really normalizing discussions around sexual health. Because we know for many patients, it can be you're in a very vulnerable position, coming in, you may have met the provider for the first time. So whatever we can do as providers to create that safe environment, I think is so important. I'm also wondering, I know a lot of your work, both research and clinical, has focused on the Latino community. And I'm wondering if there are specific barriers or issues that folks are confronting or facing in the Latino community, which may make engaging in HIV prevention more challenging.
I think only what I would say first and foremost is, I think for many communities of color, including the Latino community, there's been a ton of invisibility. And 40 years into the epidemic, we're still talking about some of the same things. So to be honest, as a provider and as someone who's been working for many years in the HIV space, it's disappointing that we haven't been able to evolve some of the conversations, that today we're still talking about the inequities. So I would say, first and foremost, we need to come to terms as a country that if we are going to, in fact, achieve the ending the epidemic goals, that we're going to need to straight on address the inequities. That means every single provider seeing HIV prevention and treatment as part of their repertoire of what they will bring forward in care. It also means being able to ask tough questions. It means being able to extend our services to the populations that are most in need. It means getting comfortable as providers with our own biases and really owning that oftentimes the data suggests that our patients do not see us as being trustworthy. We typically focus on whether or not the patients trust us versus are we trustworthy?
Yes.
How are we signaling our trustworthiness in that clinical interaction? It also means really monitoring our behaviors and really thinking through when we have judgments or bias, or we have gut level reactions when someone comes in, we don't like them. And so we treat them differently. We fail to raise, certain questions or issues, or even in many cases, and I know that this is true, the data supports this, although I think it's been hard for many of us as providers to accept that we may not even be following protocols and offering what we know are the sort of life-saving preventative treatments to all people that come through our doors. That's a tough one, Oni, for me, because I know that individually we all care about providing health to people, healthcare. But the truth of the matter is the data supports that oftentimes collectively we fail at being able to ensure that we're providing the correct protocols to each and every patient.
Exactly. No, this is such powerful lessons learned and things that we need to do as healthcare providers to ensure that our patients are receiving evidence-informed, evidence-based care. One strategy that I've really enjoyed using with patients in terms of talking about PrEP is something I use, like the ask, tell, ask model. So I'll be like, well, tell me what you know about PrEP, or would you mind if I share with you some information about it? And then I often then, will they say they give me their permission. And so I'll say, okay, well, this is what we know, blah, blah, blah. And then they'll say, oh, wow, okay, well, I did know this, but this is something new. So I think also just creating opportunities for our patients to really ask questions, to sort of react to what information that we have shared with them, and to do in a way that is sort of centers their autonomy. So always, instead of just launching into oh, you should know about PrEP, asking is it okay if I tell you about this, if I share this information with you? And I'm wondering for you, other strategies that you have found helpful. Well, you talked about, again, normalizing sexual health discussions, coming from a place of non-judgment, open-ended questions, probably really helpful.
Yes. I mean, I love what you said about ask, tell, ask. I think that's a great strategy. And I think many of the things that you just repeated that I shared are things that I bring to my work with young people. But I would say, even with adults, but certainly with young people, just expressing an interest and concern in their lives and trying to understand what do they want out of their sex lives and how can I optimize the positives while reducing things that, if you ask young people or patients in general, they don't want a negative outcome. It's just getting really open and honest about how we can plan together to really prevent that from happening, while accepting whatever it is that they're doing and supporting them in pursuing what their goals are. I ask often, Oni, when I see people, what is it that is most important for you to get out of today's visit? And I start with that. And then I say, well, can I ask you about some things that are on my mind? And so again, it's a give and take. It's a relationship. I think that, expressing that you care matters an awful lot.
Oh, I'm going to steal that one from you, if that's okay. I really, really love that approach. And I think it reminds me of the framing of what matters to you, asking our patients what matter to them, what are their priorities versus what's the matter with them. I think we come at them from, have these discussions from a risk perspective, our patients can really begin to disengage. So I really love that. So again, really keeping it open-ended. I also like to just reflect back, when I'm hearing it sounds like you've taken a lot of, steps to stay safe or to protect yourself from HIV. I'm wondering, but it seems like you have some concerns about the safety. Let's talk about that. Because sometimes it can be a little hard, in these discussions. So I try to encapsulate it too, just to reflect back what I'm hearing. So I think just very clear from what you have shared, also so many strategies that we can use as healthcare providers to create a safer space for many of our patients to have these discussions.
You know, one of the things that you just shared that I love so much is, at the beginning of our session today, we talked about sort of PrEP indications and eligibility. And those clinical guidelines, a lot of it's focused on risk. Mm-hmm. And we have to repeat that because those are our guidelines. But the thing that is really challenging is that often when we encounter a person, certainly in my practice, I'm not really talking about risk. I'm talking about sexual health. And I think the more that we make it about risk, the harder it is for people to say, hey, in the past 6 months, I did have an STI, or I do have a new partner, or I engage in anal or oral or vaginal sex, or I use crystal meth and I inject. And I think part of what we want to do is create an opportunity for people to share what's really happening in their lives and to sort of partner with them in how we can preserve the parts of their lives that they want, that are positive, while also reducing the harms. And they want that, but they don't want our judgment as providers. They want us to kind of keep it real and be open.
I love that. Okay, that's such a wonderful note to for us to think about, and in terms of moving to like potential resources that either like patients potentially could use for like finding out more information about PrEP, or finding like PrEP providers. Are there any like go-tos that you share with patients or folks that you are maybe in conversation with around HIV prevention?
Sure. I typically use the HIV.gov website. There's Ready Set PrEP, which I think is a great resource. I also, I like that it provides free medications, particularly for people that are uninsured or underinsured. I love some of the campaigns that are there around stigma reduction, which I realize, in order to make PrEP sort of really reach people, we've got to not only provide the laboratory and clinical supports and the medications, but we've got to help people to be comfortable with PrEP. And I think some of that stigma reduction is really critical. I think, some of the Please PrEP Me site or the HIV source site, I think Greater Than HIV, there are a number of sites that are really useful that I think are out there. And then I would say, only the places that I love the most are really the comprehensive sites that just don't focus on one aspect. And so one of the sites that I really love is something called the bedsider.org, which has contraception and PrEP, and it has has STI information, and it's got a clinic locator, it's got an interactive tool for asking a question and getting a response. There's also Planned Parenthood's chat text program where you can get a live person to answer your question. That one's pretty cool. I've sometimes put a question in and gotten a live response back. Great. And it's just, I just love when people can get accurate information that they can access on their own.
This is so awesome. No, thank you. You shared so many, I think, really excellent sources and sites that both as providers, but also as patients that can be used. So this is really, really wonderful. I also know the CDC has Let's Stop HIV Together resources, and some of them are also focused on PrEP as well. And just want to say your point around the comprehensive sites, I feel like I really appreciate that, because I think also, PrEP is not just about, it's about sort of like, not just the medication, it's a bundle of care, and it's about sort of holistic care and, focus on someone's sexual health. And I think that can also help to destigmatize, HIV prevention and HIV more generally. So thank you so much. And I think we're going to, to draw to a close and just share some summarizing or some final thoughts with the audience that we hope you were able to take away and are able to apply to your clinical practice. One is around really identifying appropriate PrEP options for your patients based on what the indication might be and the delivery method of that approach. Recognizing and addressing drivers of PrEP inequities in your local community and practice environment. I'm sure a lot of what Dr. Guillermo Ramos shared and some of what I may have mentioned also might resonate with you when thinking about things that you're seeing, some of these structural drivers of HIV inequities. Using open-ended, non-judgmental approaches like the ask, tell, ask method when we're talking to our patients about PrEP or when we're wanting to initiate those discussions, also open-ended questions as well. And then, wonderful tools and resources that were just shared by Dr. Guillermo Ramos to really get folks, educated and informed about PrEP, so we can also work with them so that they're able to make the best decision possible for themselves in terms of their sexual health. And thank you again so much to Dr. Guillermo Ramos for joining me today, for sharing your wisdom, your expertise, all of it. And thank you to our audience for participating and providing the best care for patients. Take care.
Thank you so much, Dr. Blackstock. It was my honor. Thank you.